Well, the plan was that I'll be teaching you guys the blue and the pink deposition diseases, right? Okay, so we'll get started with that. So what essentially I mean by blue and pink deposition diseases is um, mostly iatrogenic diseases. We'll be talking about, which not iatrogenic, sorry, endogenous diseases, which result in the deposition of either mucin or mucin-like substance. You guys can hear me, right? Okay. Mucin or mucin-like substance and amyloid or amyloid-like material. So the blue refers to mucin and the pink refers to amyloid or amyloid-like. These are a group of diseases which could be, okay, so now we are good. Okay. So so we're referring to blue and pink deposition diseases. So these will be a group of endogenous diseases which are producing either mucin or amyloid-like material or amyloid. So referring to the blue deposition diseases, these are the entities which are all board textable, starting from pre-tibial myxedema. We'll talk about plaque-like cutaneous mucinosis, and then even solitary neoplastic lesions like myxoma or focal cutaneous mucinosis, digital mucus cyst, mucocele, and then coming back to inflammatory entities like lichen myxomatosis, scleromyxedema. Included in this disease is also nephrogenic systemic fibrosis, which per se is not really, doesn't have a lot of mucin, but it comes under this disease category. And then you have sclerodema, follicular, and then follicular mucinosis. The last, these three mentioned entities are largely secondary entities in which you get the mucin is not the primary disorder. So these entities and the connective tissue diseases we have already touched on before. And then you have the group of diseases where, mucin occurs as a result of genetic abnormality, which is mucopolysaccharidosis. So let's start with your blue deposition diseases. So pre-tibial myxedema. So even though all these diseases are characterized by the presence of mucin, mucin is not going to be very obviously seen. When you see a ton of mucin in the slide, which is like right away visible to you as the main pathogenic disease, the two diseases you are thinking about are pre-tibial myxedema and reticular erythematous mucinosis or plaque-like cutaneous mucinosis. So again, remember, if you're seeing a ton of mucin, which is the primary finding, these are the two diseases you think about: REM or plaque-like cutaneous mucinosis and pre-tibial myxedema. Pre-tibial myxedema doesn't have inflammation at all. So it is essentially you take out the mucin, everything else is normal. So you'd have a ton of mucin with minimal other inflammation. Other findings, such as finding some degree of stasis change on the legs, can help you in recognizing its location. But largely, you will just see mucin deposition in the absence of any other significant inflammation. Now, you take this similar biopsy with a lot of mucin and you put a perivascular lymphocytic infiltrate like tumid lupus like infiltrate, but with a lot of mucin, that becomes reticular erythematous mucinosis or plaque-like cutaneous mucinosis. So, this is an entity which has a specific clinical pathologic correlation. You cannot diagnose this entity in isolation, and many people consider it to be a variant of lupus. And in all honesty, it is a variant of lupus because in the clear scenario, it may be very difficult to distinguish it from especially the tumid variant of lupus, but obviously the clinical is going to be very different. This is REM, and you can see that there is a nice lupus-like infiltrate with lots of mucin. So, some people say that REM doesn't have much perifollicular inflammation. The inflammation is in the superficial and mid dermis as compared to the deep dermis, with tumid lupus having a lot of perifollicular inflammation. But honestly, these are not the specific findings. You largely have to correlate with any other question that they are asking you. But the mucin is very prominent in REM or plaque-like cutaneous mucinosis, in contrast to tumid lupus, where you often recognize the lymphocytic infiltrate and then go ahead and look for mucin. So pre-tibial myxedema is a far more important board question as compared to your REM or plaque-like cutaneous mucinosis. The other thing about pre-tibial myxedema, please remember to study its second order questions. You guys are pretty good with that, but the kind of mucin deposited in pretermal myxedema, I believe, is different. I'm not remembering, but please look that up. So that's something which is important. And then again, the action of the long-acting thyroid stimulator. So with the fibroblastic proliferation, which results in mucin production. So why is the mucin formed? Please look that up and, read about it. That's important. Okay, so next, coming to your kind of like your localized entity. So, from inflammatory, we are going into kind of like a little bit neoplastic. So if you see lots of mucin, but it is a solitary lesion, which is forming a papillonodular lesion, so, that would be focal cutaneous mucinosis or a myxoma. Traditionally, it is not really important to distinguish between focal cutaneous mucinosis or a myxoma. Uh, if it is a papule coming with an impression of a nevus or a BCC, it's a shave biopsy, superficial mucin. I like to call it focal cutaneous mucinosis over a myxoma. And myxomas typically are larger lesions, more well circumscribed, have deeper mucin. And because it is really a tumoral entity, another finding in it is this shredded collagen fibers. So you see these shredded collagen fibers with lots of mucin and really a mass forming lesion. But honestly, the distinction between the two is not that important unless and until they are referring to like a second order question, like its association with Carney syndrome. So you can see the shredded collagen and you can see the mucin. There should be no cellularity within the lesion. So you should not have areas of hyper or hypocellularity. That's important. And you should not have any cytologic atypia within the lesion. So when you're dealing with hyper and hypocellular areas with lots of mucin, you're likely dealing with the low grade fibromyxoid sarcoma. And when you're seeing a lot of atypia with this mucin, you are either dealing with like a myxoid malignant fibrous histiocytoma or a myxofibrosarcoma. Again, entities which, if they are giving you on your boards, they're likely wrong answers. So when we will do soft tissue tumors, I'll give you some pointers on what answers not to pick unless and until they're asking a really specific second order question with it, and those would be those entities. So myxoma is far much more common than those other myxoid sarcomas that I spoke about. So this is a myxoma. Okay, the next one is you guys are all familiar with it, digital mucus cyst. It is referred to as a pseudocyst, has a classic location near the nail bed, can cause complete onychodystrophy. So, it's an important diagnosis to make. The digital mucus cyst, it produces this bubble-like space. So you will see acral skin. The epidermis overlying it is very thinned out and it forms a well collarette around it. The mucin is deposited in the stroma with these kind of like angulated fibroblasts. Again, it's not a cellular lesion, and this produces you a bubble or a pseudocystic space. So there is no true space there's no lining, epithelial lining within the cyst. It's a pseudocyst, digital mucus cyst or a pseudocyst. This is actually considered to be like the superficial variant of a ganglion cyst. So if it occurs deeper, we call it a ganglion cyst. So this is a digital mucus cyst. Again, if you have seen it once, you will always recognize it. The next one we're going to talk about is another lesion, which is mucocele, which typically occurs because of a blocked salivary duct of the minor salivary gland on your lower lip. And the mucocele basically comes in varying flavors. So a couple of things. This is a classic mucocele, what I'm showing to you. It has all the features. You recognize it to be the mucosal epithelium. Why? Because there is no granular cell layer. So you see a epithelium with no granular cell layer, so you know you're dealing with mucosa. Then you're seeing the minor salivary gland tissue. Recognition of the minor salivary gland tissue by itself is a board question. So you guys should know it. So you should see this. This is how you recognize minor salivary gland. This is how it looks like always. So you know that you are in a mucosal site which has salivary gland tissue. And then here you see it's again a pseudocystic space because there is no true epithelial lining. The pseudocyst is lined by reactive fibroblasts and granulation tissue and histiocytes, as you can see in here. And the blocked duct, the dilated duct, has leaked all this mucin, which is producing this inflammatory reaction. And you can see mucin in the pseudocystic lumen. So this is a classic mucocele. It has all the features of the mucocele. You may not get all the features, so then you have to infer from the site that this is maybe a mucocele. So you can see here, this is the mucosal epithelium in this biopsy. Over here, you have the minor salivary gland tissue, and you lack the pseudocystic space, but you have the mucin. So that is a ruptured mucocele again. And then sometimes you may not see the mucin at all. And that is because all the mucin has been phagocytosed by the histiocyte. So you just see the mucosal epithelium, you see the nice salivary gland tissue, and you see a pseudocystic space with no mucin, but lined by histiocytes and granulation tissue, which have the mucin inside them. So if you were to do a colloidal ion stain, you would see the mucin inside them. I'm not a big fan of doing any special stains for mucin, but in case if they ask you for your boards, the mucin stains are colloidal ion and crystal violet. So crystal violet and colloidal, not crystal violet, I'm sorry, colloidal ion and I'm forgetting the other one. It will come to me, but colloidal ion is the more common one. I'm not a big fan of doing those stains because you can see the mucin. You really, doing the stain in my instances, sometimes it confuses you. So, but if they ask you for your Bose colloidal ion is a stain for mucin. So this is again an example of a mucocele, ruptured mucocele. The next disease entity we're going to talk about is papillomucinosis or lichen myxomatosis. So this is it's a complicated disease entity, something that you're not going to frequently encounter. Questions regarding papillomucinosis and lichen myxomatosis are more for like the dermatopathology fellows, but they can be asked. And if they're asking you and you're getting it, then you're way above high in your percentile. So it's an important entity to know. So clinically, papillomucinosis or lichen myxomatosis, typically the patients have a papillar eruption, right? Most commonly involving the upper extremities, so the upper part of the body, but it could be, it could be anywhere. And when you biopsy the lesion, this is how it looks like. So the entire process is going to be localized in the upper and the mid dermis. So remember, it's a papule. So it's a superficial process. It's going to be an uninvolved epi. It's a dermal process. So you will see involvement of the upper and the mid reticular dermis. So that's where the lesion is. So that's important. And then when you look at it on low power, it actually gives you the differential of a busy dermis. So you really don't know much that is happening. The findings are subtle, but what you do see is the findings of a busy dermis. So you see a very busy dermal infiltrate. On low power, hence the busy dermal appearance can give you the appearance you can think about, is this an interstitial GA or GA? That's probably the most common thing that you guys think about is GA. The other thing you can think about is inflammatory morphia. Okay, and I'll explain you why you think about that. But you guys are not experienced enough to think about inflammatory morphia, so we will leave that away in the differential. You guys will think about GA, however, because of the busyness in the dermis. However, it differs from GA. The reason it differs from GA is because there is no necrobiosis. There is no altered quality of the dermal collagen. However, what you do see, and unlike GA, where there is no fibroblastic proliferation, this has fibroblastic proliferation. So the busyness in the dermis, you remember this way. Papillomucinosis equals to everything is increased in the dermis. So what happens is that you have fibroblastic proliferation. So you can see that the nuclei of the fibroblasts are increased in number. Not only are they increased, and they are randomly oriented. So some of the fibroblasts, they are going like this. They are going in an east-west direction. Some of the fibroblasts are going up and down, so in the north-south direction. So randomly proliferating fibroblasts. Once you start noticing that, you will really pick it up. Yes, the fibroblasts in this field are very randomly proliferating and oriented, and they are increased in number. When they are increased in number, they will also lay down some collagen. So it will produce you slight dermal thickening, but it is not going to be that much what you see in morphia. Okay. So there is increase in collagen, but there is also subtle mucin. So you have fibroblastic proliferation, you have increased collagen, and you also have mucin. You have mucin, which is again not very obvious. It is going to be subtle, but it is going to be there. And that's what gives you the busy appearance. Besides this, you also have an accompanying inflammatory infiltrate. So there will be lymphocytes, there can be some eosinophils, so it can be a mixed infiltrate. Okay, so that is the findings of papillomucinosis and lichen myxomatosis. Perhaps the most important finding it's like kind of like a diagnosis of exclusion. So that's what you have to think about in your head. But the most classic finding is this fibroblastic proliferation with the north, south, east, west direction, along with the mucin and the thickening of the dermis. So now, what is the importance of finding out papillomucinosis lichen myxomatosis? What do I do with it once I diagnose it? Once you diagnose it, you have to be able to correlate it clinically. So the clinical in this particular scenario is going to be very important. So when you are diagnosing papillomucinosis, in the clinical connotation of it is you largely want to put it into three categories. Is the patient's blood completely normal, no paraproteinemia, in which case it is just localized papillomucinosis, and we'll discuss that in a little bit more detail. Or if the patient has a paraproteinemia, so you will always ask the clinician to do serum and urine protein electrophoresis, right, to determine paraproteinemia. The patient does have a paraproteinemia, but the patient does not have any features of scleromyxedema, then it is atypical papillomucinosis. But if the patient has underlying lymphoproliferative neoplasm, paraproteinemia, and has the features of the generalized skin thickening, leonine facies, internal organ involvement, then that is scleromyxedema. So this is what is the importance of it. So if the patient doesn't have, so typically when I diagnose papillomucinosis or lichen myxomatosis, this is what I tell the clinicians to do. The most important thing is to do the protein electrophoresis to make sure that there is not SPEP or UPEP, complete blood count, make sure everything is normal hematologically with the patient. Next thing, you also want to do Hep C, HIV, and thyroid function tests. And the reason I will tell you that thyroid function test is obvious because, mucin deposition, papillomucinosis can be seen in patients with myxedema, with the hypothyroidism and these infections. And the reason I'm talking about these infections is because of this. So once you know that the patient does not have a paraproteinemia, your localized papillomucinosis can fit into any of these disease categories, or it may not fit into any of these discrete disease categories. So this is why you need to go back to your derm books and you need to remember all these conditions. So localized papillomucinosis is classified into these variants. You have discrete papillomucinosis, which you can see is associated with, all these entities. And that's why the HIV and the Hep C infection comes in. Acral persistent papillomucinosis, specific type, which just involves the acral sites. This is by far the most common one that I have seen. I have seen cases of adult and juvenile self-healing papillomucinosis. They present with like morphia, like infiltrating plaques localized to a region, and papillomucinosis of infancy and nodular papillomucinosis. So I would urge you guys to go into your derm books and to read about these entities. But the findings of all these entities would be papillomucinosis, lichen myxomatosis. And then scleromyxedema is the other spectrum. So scleromyxedema is generalized lichen myxomatosis when you have systemic involvement. An important thing to remember in scleromyxedema is that both this and scleroderma, they present with thickening of the disease, thickening of the skin. So all the scleroid diseases, so scleroderma, scleromyxedema, and sclerodema, which I'll be talking about soon, they all present with dermal thickening, right? In sclerodema, it is localized. In scleroderma, sclerodema, it's localized. In scleroderma and in scleromyxedema, it's going to be generalized. And both scleromyxedema and scleroderma can present with, leonine facies and thickening of the face. But the difference important is that scleromyxedema does not have the renal involvement, and I guess has minimal renal involvement as compared to predominant renal involvement in scleroderma. So, you guys are pretty much better at this than me. You probably have dealt with this clinically, if not once, more than once, maybe in your clinical practice, but these are important points to consider. And histologically, that's also what you should be thinking about. What are the differentiating features? Scleroderma, scleromyxedema, and sclerodema. So when I'll do sclerodema, we will revise back all those findings. But scleromyxedema is papillomucinosis or lichen myxomatosis. So this is what you're going to see. You're going to see mucin. You're going to see fibroblastic proliferation with increased collagen, which is what produces the dermal thickening. You're going to see an inflammatory cells as well. Now, in case if the papillomucinosis is associated with the paraproteinemia, like I mentioned, there can be in the biopsy a lymphoplasmacytic infiltrate which can be restricted. So sometimes that can be a clue. So if we get a biopsy for papillomucinosis or lichen myxomatosis, and we see a decent number of plasma cells in the biopsy, we can actually do kappa and lambda in situ hybridization and determine if that is a restricted pattern or not. So that can be useful. So that's the second order question that can be asked. So what is the second step you would want to do? So that would be, if it is showing a plasma cell infiltrate, which is a decent amount to be worked up, you can do kappa and lambda in situ hybridization on the biopsy to determine if the patient has an underlying paraproteinemia. That will still not make the diagnosis of scleromyxedema because that's more of you need the cutaneous findings as well. Okay, so that was about papulomucinosa, lichen myxomatosis, or scleromyxedema. Now, this brings us to the question of nephrogenic systemic fibrosis. Now, I'm not going to dwell a whole lot into this lesion, but I would like to, discuss this with you guys a little bit. The the important thing is that NSF, if just remember this at the back of your mind, whenever you're diagnosing nephrogenic systemic fibrosis, nephrogenic fibrosing dermopathy, it is a lawsuit. So, if you're involved in it, help the patient, but also try to run away from the case as far as possible. It is a definitive lawsuit if you're getting involved in this, and you know the history behind it. Most of the cases were described in patients who had gadolinium exposure during the MRI and had renal disease. So this is the fourth disease entity which will produce you thickening of the skin. So we have talked about the 3 S's. We have talked about scleroderma, we have talked about scleromyxedema, and we have talked about scleredema. Now this is nephrogenic systemic fibrosis, which is also going to produce you diffuse thickening of the skin. It also involves the internal organs, can result in diaphragmatic respiratory paralysis, which can be the cause of death in these patients. So it is a progressive disease. Now, why is it included in this category? It's included in this category. It is not mucinous. It's more fibrotic. But the way I think about NSF is that the top looks like scleromyxedema, but it is a much more deep-seated process. So remember, I told you that scleromyxedema is a superficial process. This is a much more deep-seated process. So the top looks busy with the fibroblastic proliferation, with minimal mucin, but very much fibroblastic proliferation. That is what is producing you the dermal thickening. And that's how, by the way, you will distinguish it from morphea or scleroderma. So how do you differentiate scleromyxedema from scleroderma? You differentiate it because in scleroderma, you are getting dermal thickening, but you do not get fibroblastic proliferation. That's why picking up the fibroblastic proliferation is a very important factor. In morphea and in scleroderma, you get dermal sclerosis or thickening of the dermis, but there is no fibroblastic proliferation. Whereas in scleromyxedema and in nephrogenic systemic fibrosis, you do get fibroblastic proliferation. So the top looks very much like scleromyxedema without the mucin, okay? But remember when I taught you guys septal paniculitis, and I said enodosum is the most common cause, but then there are other 5 causes of septal paniculitis. You must remember, if you guys were paying attention, that one of the causes in there, so what were the other causes? There was morphea profunda, there was scleroderma, and there was nephrogenic systemic fibrosis. So the bottom of it looks like a septal paniculitis with septal fibrosis. So it looks like a broad band of enodosum without the giant cells and the inflammation. So the top looks like scleromyxedema, fibrotic with fibroblastic proliferation, and the bottom looks like this expanded septum of enodosum. That's how you remember nephrogenic systemic fibrosis. The other thing about nephrogenic systemic fibrosis, 2 things to remember, that these fibroblasts, they have been described to be CD34 positive, which is not a very good stain to do because it's very difficult to interpret, but these fibroblasts are supposed to be CD34 positive. However, the diagnostic finding for nephrogenic systemic fibrosis is this structure, is lollipop bodies. So lollipop bodies are these whorled pink bodies which contain the blue destroyed elastin fibers with deposition of gadolinium. So to be actually able to diagnose it with certainty, histologically, you have to see these structures, which are called lollipop bodies, and you have to confirm that they have gadolinium in their composition. So this is the defining feature of NSF, or nephrogenic systemic fibrosis. So I spent a time discussing this entity. So hopefully, let's see if it is there on your boards and if you guys remember it. But this is a very complicated entity, but for completion's sake, we talked about it. Do you guys have any questions till now? The topics of papulomucinosis and scleromyxedema and NSF and scleroderma and sclerodema are confusing. So if you're listening to me, it may be useful to chalk out in your notebooks like three or four things, right? So scleroderma, scleromyxedema, and NSF, and your which scleroderma, which one did I miss now? Scleroderma, scleromyxedema, sclerodema, and nephrogenic systemic fibrosis. So, and try to like summarize what I just said. Should I give you like 2 minutes to do that? And if you guys have any questions, ask me. Do you want to do that or you don't want to do that? Then thumbs up. Everybody understands that? Any questions? Okay, let's do sclerodema and then ask me any questions, okay? So sclerodema is the next entity with the dermal thickening, right? So let me pull up a slide of sclerodema. So sclerodema, unlike the other diseases that I talked about, is actually an invisible dermatosis. It's a beautiful example of an invisible dermatosis. By invisible dermatosis, I mean that when you first look at the biopsy, basically nothing looks wrong with it, okay? Except the fact that the dermis just doesn't end. It's very thick. But thick, by thick, I mean that it is very, like, it's very, it will have the adnexal structures in it, but it just doesn't stop. You don't see the fat. And when you look into the composition, unlike morphia and scleroderma, where the space between the collagen bundles is obliterated. So you know something is sclerotic if the space is obliterated between the collagen bundles. Here it is opposite. The collagen bundles are swollen and separated. So swollen and separated. And what separates them is actually invisible mucin. Okay, so there is mucin in between these separated collagen bundles, but you're not actually seeing the mucin. This is important. So in entities like this, it may be useful to do the colloidal ion stain where you're not at all seeing the mucin and colloidal ion might highlight it. So that's sclerodema. It's got no inflammation whatsoever. It's a thick dermis with the collagen bundles which are swollen and separated. And what separates them is actually mucin. So in contrast to morphia scleroderma, where the space is obliterated, but there is no fibroblastic proliferation. And in scleromyxedema, it's everything. You have the mucin, you have the fibroblastic proliferation, you have collagen deposition, and you have the inflammation or a restricted plasma cell pattern. Morphia and scleroderma will also have a lymphoplasmacytic infiltrate. In fact, they can also have eosinophils. Okay. And nephrogenic systemic fibrosis is going to be with minimal mucin, with fibroblastic proliferation, thick dermis, but also with an associated septal fibrosin thickening and the lollipop bodies. Okay. So now you guys want to summarize it to yourself and tell me if you guys didn't understand something.
Why don't you see the mucin in sclerodema? Why is it invisible?
I don't know. It's a good question. I don't know why we don't see the mucin. It's there. I think it's so little that the histology, maybe preparation doesn't pick up, because there are some instances. I do have some cases where I can see it, but it is very subtle. Like you have to look for it. And that's why this is probably the only entity where I would like to do the colloidal ion stain. But it's a very satisfying diagnosis when you make it. So, because truly it's an invisible dermatosis. The other thing which you never think about, what you will confuse this with, you know, is what? When you get a biopsy of sclerodema, what you guys confuse with? You will never think when I say this, is actually macular amyloid. The reason is because where is macular amyloid most commonly located? Where do you biopsy the lesion for macular amyloid?
Back.
Back. When you biopsy the back, what is the dermis of the back? It's very thick. Right? So when you do a biopsy for macular amyloidosis, when you do a punch biopsy, the biopsy is the dermis looks thick because it's the back, but it is not really thick. And it is an invisible dermatosis. So on low power, it actually looks like sclerodema. And that is why I always tell the residents, when you are thinking about macular amyloid and sclerodema, the other thing to do is to look for pigment incontinence. More than the amyloid in macular amyloid, which I'm going to show you guys very soon, it's a pigment incontinence, which will help you to go and look at the dermal papilla to make you recognize the amyloid. So if a biopsy is very thick dermis, but it has pigment incontinence, you're dealing with macular amyloid and not sclerodema. Okay. Okay. So so those were the primary causes. And then I'm not going to talk about follicular mucinosis. We're going to talk about it when I do cutaneous lymphoproliferative disorders. There are going to be some slides of follicular mucinosis when you are dealing with your study set. But let's go into your the pink diseases. Okay, so the pink diseases. And then the mucopolysaccharidosis. Mucopolysaccharidosis is going to look just like your any mucinosis. I've never seen a case of it. It's going to probably look like not papillomucinosis, sorry, like focal cutaneous mucinosis. But obviously, a lot of second order questions can be asked. The genetic predisposition, the X-linked versus uh, uh, is it autosomal recessive or dominant? I don't know, because I don't need to know, so I'm good, but you guys should know about it. And then this is the question they like to ask you. This is not something that you will recognize on histology, but you can actually see it on histology, but I've never seen it. But this is a nice question. Metachromatic granules are seen in the cytoplasm of the fibroblasts. Coming to your pink diseases. So pink diseases are basically more amyloid or amyloid-like. So the amyloid is going to be classified as something which is just in the skin and is not made up of true amyloid protein, and that's macular lichen amyloidosis. The amyloid in this is made up of keratin filaments, so that's important. And then you have nodular amyloidosis, which could be in the skin or it could be associated with systemic paraproteinemia. And then you have systemic amyloidosis, where the skin is secondarily involved. The other amyloid-like materials are gout, colloid milium. And then we will talk about specific diseases like cutaneous collagenous vasculopathy. I'll quickly mention about that. And then you have these entities which are very rare, lipoid proteinosis and erythropoietic porphyria, but we will talk about it. And then you should know that the pink perivascular deposition, which we talked about in blistering diseases, can occur in porphyria and pseudoporphyria. So we'll talk about that. And then lastly, Waldenstrom's macroglobulinemia. Okay, so let's go to your pink deposition diseases. So the first one is going to be, let's talk about macular amyloid. So as I said, in your macular amyloidosis, in this particular instance, the biopsy is actually not that deep. It's the biopsy, I don't know which part of the skin that they're biopsy. The dermis doesn't look very thick over here, but you can see that there is nice. This is what you're looking for. You will always see some pigment incontinence. So the pathophysiology of macular amyloid is chronic rubbing and scratching, right? So something like notalgia paresthetica. So when the epidermal keratinocytes get really irritated, they will leak their keratin filaments, which will get deposited in the form of this amyloid-like material. So this amyloid-like material actually will stain with high molecular weight cytokeratins. The stains for amyloid are crystal violet and Congo red. Okay, so you should know those two stains. So crystal violet and Congo red. For macular and lichen amyloid, we prefer to do crystal violet over Congo red. And this amyloid material, specifically in macular and lichen amyloid, will stain with high molecular weight cytokeratins. And their composition is something that they like to ask you in your boards. So this is macular amyloid, minimal inflammation, just deposition of this amorphous eosinophilic pink deposits, which are filling and expanding the dermal papillae with minimal inflammation. And there's going to be pigment dropout. So that's macular amyloid. This stains with crystal violet, Congo red, and it will also stain with your high molecular weight cytokeratins. The next one is lichen amyloid. That occurs more like a pruritic papillary eruption on the lower extremities. And what you see are, it's not really important to distinguish between macular and lichen amyloid. The location will basically be helpful. The changes in the epidermis are more prominent. There is more inflammation in lichen amyloid. Macular amyloid is more like subtle and invisible. So here you can see that the dermal papilla is filled and expanded. There is lichenification on the top. There can be patchy lichenoid inflammation, pigment incontinence, but you can see this amorphous pink material which is filled and expanded the dermal papilla. Again, the composition of this would be similar. Keratin filaments, high molecular weight cytokeratins, and crystal violet would be positive. Coming to the next one, which is your nodular amyloid. So nodular amyloid doses is something that, the patient will definitely need to be worked up. So where is my slide gone of that? Okay, here. So in nodular amyloid, it's more of a diffuse dermal infiltration. So what you will see is kind of like effacement of the normal dermal architecture. Uh, it loves to get deposited around the vessels, but you can see here the normal collagen tissue architecture of the dermis is altered by this very pink homogeneous material. This is exactly how systemic amyloid deposition will also look like. So you absolutely will have to work this patient up to make sure that there is no paraproteinemia. Another thing that you can get in a biopsy of nodular or systemic amyloidosis is a lot of interstitial hemorrhage. So sometimes there is so much of blood that it can be a clue that this may be amyloid. Why does this happen? Because the vessels are where it's getting deposited first around the vessels, so they become leaky, and that is what will produce you the raccoon eyes in a patient with systemic amyloidosis. So you can see the nice amorphous pink material. This will show the apple green birefringence on polarization light microscopy with Congo red. So Congo red is a stain that we basically like to use for that. Okay, this is going to be in contrast to gout, where the in amyloid, the material is acellular, very homogeneous, right? But in gout, it's actually needle-like crystalline. So you have these needle-like crystals, which are your sodium monourate crystals, and there is going to be surrounded often by an inflammatory response. So on low power, this can actually look like a palisaded granuloma, especially rheumatoid nodule, because of the pink stuff and then the surrounding inflammation. So this can look palisaded, but you have to go in the center of what it is surrounding. And here you will see it's nicely, these are the crystalline feathery crystals of gout. So that is gout. And again, the thing is that amyloid typically does not incite a granulomatous response, though it can, okay? In case if there is an associated ruptured cyst or follicle, you can have a granulomatous response, but typically it doesn't have a giant cell foreign body response, whereas a gout does. So this is gout. The next thing would be colloid milium. Colloid milium is of two types. You have your juvenile and your adult colloid milium. What you most commonly see is adult colloid milium, but both the entities would be similar on histology. What you see here are fractured hyalinized deposits, which have an amphiphilic tinge. So they will look both blue and pink, but they are classically fractured and they are juxtaposed to the epidermis. So very close to the epidermis like this. So if you've seen it once, you will always remember it. These cracked hyalinized deposits in the background of this elastotic collagen and the marked solar elastosis and elastotic elastin, and then you can see this kind of fractured hyalinized deposits which have kind of like a blue and a pink tinge. That would be your colloid milium. Now, this is going to be in contrast to your nodular solar elastosis, right? So that's in the differential when you're seeing that. So solar elastosis can also form these kind of like elastotic nodules like this, but this is not really juxtaposed. You can see that, and it's not fractured, and the kind of material in it is much more blue as compared to that amphiphilic fractured appearance of your colloid milium. So that's nodular solar elastosis. Then lastly, as far as the slides are concerned, I'm going to talk about cutaneous collagenous vasculopathy. So cutaneous collagenous vasculopathy is also one of those entities. If you're answering this question, you are definitely in the 99th percentile. This is more of a dermatopathology fellow kind of a question. But what you see in CCV is cutaneous collagenous vasculopathy. Clinically, the appearance is much more dramatic. So when you biopsy these patients, most of the times you actually don't know. Your clinical varies from, I've seen vasculopathy, vasculitis, livedo reticularis, lupus, dermatomyositis. So you guys are all over the place. You're definitely thinking about a connective tissue disease with some features of an overlapping vascular disease. So the clinical is much more impressive. When you look at the histology, it can actually get completely neglected. So if you have not seen this entity, you will never diagnose it before. So it is again an invisible dermatosis. Not much is happening on low power, not much inflammation, but the vessels look abnormal, and it's the superficial vessels. So the superficial dermal vessels, they are telangiectatic. So you can see this telangiectasia, like what you would see in generalized essential telangiectasia. But you have perivascular hyalinization. So you can see this pink material which is deposited around the vessels. This material is PAS positive, okay? That is a finding of cutaneous collagenous vasculopathy, dilated vessels superficially with perivascular hyalinization, which is PAS positive. The reason this happens is most often these patients, the unifying feature is they have the common diseases which most of the elderly people have: hypertension, dyslipidemia. Uh, uh, so the pathophysiology is probably some kind of a microvascular occlusion, which results in the secondary vascular telangiectasia. So that's the pathophysiology. But that's CCV, cutaneous collagenous vasculopathy. Then lastly, we're going to talk about some diseases which you guys should know, like lipoid proteinosis, which is your autosomal recessive mutation extracellular matrix gene. So a lot of questions can be asked from it. Now, what about the histology? The histology will show deposition of an amyloid-like material. Okay, so it looks exactly like amyloid. You cannot tell it apart from amyloid, except that this material is oriented, it's deposited around the vessels and in the dermis, perpendicular to the epidermis. And you see what is known as the onion skin hyalinization around the vessels. So this onion skinning around the vessels is a nice feature. Okay, so this is the, you can see this hyalinized material, which is arranged in an onion skin pattern around the vessel. So that's lipoid proteinosis. This is going to be exactly the material quality is going to be is similar to what is you see in amyloid. It's not amyloid, but it's similar to what you see in amyloid, and it can actually stain like amyloid. Porphyria cutaneata, you guys more often recognize it with the subepidermal blistering disease. And remember, we talked about that the subepidermal blisters, the base of the blister cavity will contain perivascular hyalinization. So the pink material around the vessels is a clue for PCT. In erythropoietic porphyria, which is more of a younger age disease, you basically see the same, you don't see blisters, but you say the same material deposited around the vessels, which is oriented perpendicular to the epidermis, in the background of disproportionate solar elastosis. So it's a younger individual, but you have marked solar elastosis. So, and the perivascular deposition oriented perpendicular to the epidermis. So those are the clues. And then Waldenstrom's disease. Waldenstrom's disease, can have a lot of manifestation in the skin, right? Waldenstrom's disease can present like a thrombotic vasculopathy, type 1 cryoglobulinemia. It can present with a restricted plasma cell infiltrate, can present as secondary association with xanthogranulomas in a patient with xanthoma disseminatum. So it can have varying disease manifestation. But as primary in the skin, we think about it when it contains these hyalinized deposits in the papillodermis, which contain monoclonal IgM. This would be a fantastic case report to write. I do not expect you to be diagnosing this on a biopsy. It will require a good amount of workup because, again, this material will look indistinguishable from amyloid, but this is just something you should keep it at the back of your mind. Okay, this is more for completion's sake. So again, these are the board questions which are going to be asked. So as long as you guys can recognize pretable myxedema, papillomucinosis, very less likely this, focal cutaneous mucinosis, myxoma, digital mucuses, mucocele, sclerodema. And then in the amyloid category, you need to know all the kinds of amyloid, gout, colloid milium, and then all of these others are, less likely entities. So do you guys have any questions? Good. So I will share some study sets with you. Deposition disease, I don't remember if there are 1 or 2 study sets. So some of those study sets will have overlapping diseases like morphia and stuff in it, okay? Because you when you are dealing with these diseases, you should keep morphia, scleroderma at the back of your mind, even though that's comes in a different disease category when I'm going to be teaching you guys. But when you're attempting it, remember that morphia and scleroderma are fair questions to be asked. So we'll do some study sets the next time, which I'll send to you guys. Does that sound good?